what we wanted to do to finish this time was really to start the digestion process for yet another successful Target ALS meeting. And the quantity and quality of data unpublished that gets shown here each time is just amazing. And the impact that has on each of you will be different, obviously. It will be delayed, probably, as you think about it, look back at your notes, and delayed because you'll be discussing it in the consortia and with new collaborations we've seen formed on the stage. So what we thought we'd do would just invite 3 experts, 3 friends of Target ALS, to come up and just share their impressions, not only of the meeting, but where we stand in the ALS field at the moment and where we might be going. So we don't have a long time, so I've asked them to focus on just 1 or 2 examples. So I'm saying in advance, if your field isn't mentioned, if your project or speech isn't mentioned, it's my fault, not theirs. So we're going to start with a couple of general questions and have a discussion between us. I'm going to introduce them, and then each of them will answer a question more specifically in the area. So I'd like to introduce, oh, you can just see Carole. Is that right? Oh yeah, you can see her on the side of your screen up there. Carole Ho from Denali, who was here earlier in the meeting, but is now calling in from the top of some mountain somewhere. We have Toby Ferguson from Voyager Therapeutics and Pietro Fratta from UCL, all so well known in the field, I don't think I need to introduce them more. So I'm going to sit down and try and moderate this. And we're going to start with the first general question, and that involves me knowing how this slide clicker works. So, a question for all of you, and we can have this, I think, as a general discussion, is what is the single advance over the last 3 years that has moved us closer to effective treatments for ALS patients? And how has Target ALS helped with that? And single means we can have 3 if we like between the discussion, but maybe Toby, I'll turn to you first.
Thanks, Christian. Thanks for the chance to comment. So I do think, and probably not a surprise to this crowd, I do think the approval of tofersen in 2023 fits within that time frame. And I think it has lessons, of course, for that population of people with ALS, but also for the broader population. Just to recap, we saw in that context of those studies an initial response in a biomarker SOD1, then a response in a biomarker with a substantial reduction in neurofilament, and that reduction preceded and eventually predicted a substantial clinical effect. And so just the concept that we've then seen that biomarker move quite substantially, then get accepted by the FDA as a tool for approval, really quite important. And I think my colleagues are going to comment a bit more on this aspect as well. But I think stepping back, what is a high level and very general lesson I think we should take away from this experience and for the broad field of ALS is that in the context of the right target, the human nervous system in people with ALS is capable of being effectively treated. And I think we all thought that was the case and hoped that was the case. I think now maybe we now have data to that point. And maybe I'll now turn to Carole and Pietro to offer some more comments.
Yeah, I guess, if I can just add, 2023 was crucial, but I think what happened since as well, and meaning how actually tofersen held and everything held in the real world and really in proper clinical practice. But to me, a further aspect is that, it probably could be better. Not all patients respond the same, but the fact that some patients did get better and that the same observation has been done in some cases with FUS ASOs, that's really important. It's not just important as a matter of hope, but it's actually important in the biology. It tells us that, there is still untapped and probably silent nervous system there that we can try and awake with therapies. And so that's really been quite, I think, both a motivation, but also a really important biological, kind of discovery we've done through a clinical trial.
Mm-hmm. Carole, any thoughts on this one?
Yeah, I'll just add to that. Both the success of tofersen as well as the utilization of NFL has shown that the marker earlier in the course demonstrated treatment effect is really quite transformational and gives us a lot of optimism. I think I just want to call out Target ALS's specific role in supporting research NFL, including grants to Biogen and WashU 2020, and then now with the global natural history study, was really quite moving to see that data replicating real-world data that was presented in the first day of the conference. I think, though, it's a start, and what we want to now see is whether we can target other mechanisms to address ALS disease that is not SOD1, and I think this is the opportunity ahead of us.
Yeah, and so, I mean, SOD1 ALS is an ultra-rare disease, even by the standards of rare diseases. And this tofersen's an amazing drug, but probably some of us think we could do better with SOD1 even. So how do you think that there's a challenge with that? There's an effective drug. I'm not asking anyone to give their commercial strategies or whatever, but how can we deal with that as the technologies improve, going back to some of these disorders and doing better for SOD1 patients? Toby, imagine you were still at Biogen.
I mean, I think, Chris, you frame a really important question is in rare disease and in ultra-rare disease, if you have an effective therapy, is further innovation possible given the constraints of the size of the population, given the presence of an effective therapy? So really, really critical question, because fundamentally, no drug is perfect. Tofersen certainly isn't perfect. And you can always visualize improvements. I think fundamentally it comes down to, I think we'll clearly have some emerging technologies that can improve delivery. You can think about shuttles, you can think about gene therapies across the BBB. There are lots of things that could improve the general presentation of this drug, the general biodistribution of the drug, the safety profile of the drug. Then I think you get into clinical development, and here's where you're gonna have to have creative options, particularly biomarkers, to really get you through, is this something better? And a biochemical tool, which gives you quantitative, relatively less variable than a clinical endpoint, really gonna be critical. So I think it's certainly possible, but creativity is needed, biomarkers are needed, and I think there's a path.
Yep. Any thoughts on Carole? You're also working in a very active company in this field. And in other rare diseases, actually, you've done wonderful things. So how do we do this, making sure we go back and bring the benefits of the newly developed technology to the rare diseases for which we first had programs?
Yeah, having been involved in 3 clinical trials over the last decade that unfortunately were not successful in ALS, I think we need to think about how do we take those learnings and apply them to the next generation of programs. And there were some really interesting talks here on cryptic exons, some questions also for the Denali program on whether this mechanism had an effect on cryptic exon expression. And these are the kinds of questions that I think as a community we need to continue to address together. While this field has seen failures, these failures are always an opportunity to learn. And I think as we do rigorous drug development, really use biomarkers to help inform that we've gotten the right dose, that we've gotten, we've hit the target. This is all very important for us in understanding more about the disease biology. I think one area that I think is so important as we look at some of the challenges that we've had in clinical trials is diagnosis of patients. Diagnosis early. As a former practicing neuromuscular neurologist, I think there was always a challenge with speed of diagnosis and the reluctance as a physician to diagnose a patient with a disease for there were not good treatment options. But that can't get in the way of identifying patients early so that they can access therapeutics that are in development in clinical trials. And there is more, I think, that we can do as a community. Use these biomarkers and pathways that we're identifying and use these also to help aid the diagnosis so that we can access patients and get them involved in clinical trials at the point of presentation, not 6 months, a year after the diagnosis has been made, and then the logistics come into play of getting them into a clinical trial.
Yeah, well, thank you. I've got another question for you all, actually. Of all the exciting emerging data in the field, including the ones at this meeting, can you tell us about 1 or 2 that you feel could be game-changing over the next 5 years? I think there are more than 1 or 2, but Pietro, you have your first go at being selective.
Okay, well, I mean, also quite close to what we do, but I think it was really covered by many people at this meeting and beyond Target ALS is the development of TDP-43 biomarkers. It's all good what we heard about NFL and SOD1 trials. It's all good that that's what we have, and there's platform trials now using NFL as a measure. But of course, if we could add to that measures of TDP-43, that would be really a game changer in how we assess early on therapeutics. And so we've heard a lot of that at the meeting. We've heard, Anja Schneider and group directly looking at TDP itself. We've heard approaches, moving beyond antibodies, developing aptamers, and we've heard from like the consortium I'm part of with Len Peterson and Michael Ward, work on using, cryptic exons and altered peptides as biomarker, and that's something that's being pursued by many other people beyond us. And I think we're not there yet. There's none of these things that is actually at clinical scale, but it's encouraging. It seems that all these things are in the right trajectory. And we may need them all. It may not be one of them that's going to emerge, but I think, to me, that was a really kind of positive and optimistic note, all the work, which clearly Target ALS has funded, so it's one of the priorities, but I think a right one to pursue.
No, I think it's a very excellent feed out from the deliberate emphasis of Target ALS in recent years on TDP-43. Some will turn out to be more relevant than others, but it's a real deep dive.
Yeah.
So Carole, I'll maybe go to you for your answer to this question.
Yeah, I'll just extend Pietro's comments. I think there's been a lot of focus on TDP-43 because of the aggregations that are seen in disease. And I think emerging data that there's a loss of function related to TDP-43 and the generation of cryptic exons as opposed to a gain of function. I think it was really great to hear so many different topics that converged on cryptic exons, different cryptic exons, but underlying the same mechanism that may lead to the generation of these, and the effect that this downstream splicing and cryptic exon generation can have on neurodegeneration and synaptic dysfunction and also hyperexcitability. So I think as a general mechanism, also orthogonal to what we've learned about treatment in SOD1, where we don't see TDP-43, I'm really excited that some of these mechanisms will identify new therapies for sporadic ALS.
Yeah, absolutely. Toby, there's still space, I think, for a few more things.
So we heard a lot of discussions about the heterogeneity of ALS, and that can be defined in many different ways. Mm-hmm. We also heard a lot of discussions about sort of the generation, a lot through the support of Target ALS, of these larger databases that really start to catalog human biology. I'd highlight some talks from the FUS consortium yesterday that started to look at fibroblasts in individual patients and looking at that biology and asking, did that biology in sporadic patients match a biology in a genetic subtype? That's one concept, but I think just the idea of, at a patient-by-patient level, understanding that biology and then matching that biology eventually to therapeutics, I think will be quite powerful. The disparate biology has to be addressed in some way, and I think we're starting to get there to address that on a patient-by-patient basis. I'm very excited by that.
Yeah, I mean, all of this is really a readout of what a lot of us hoped for years in terms of that. And I think one surmountable challenge is how to funnel all this information, which people are sharing so openly, into a form that can be digested by people planning trials. Okay. So maybe I'll switch now to I've got a question for each of you, as you know, and so I believe the first one is for Pietro. Probably you could talk about for 3 hours about this, but in what ways has our vision of ALS disease biology changed over the last 5 to 10 years?
Yeah, well, I mean, to me, what has really changed is, in slide 1 or 2, pretty much of any presentation, at least I do, but many of us show this neuron with the TDP aggregates and nuclear depletion. And like 5, 10 years ago, we knew that, but to me, that was a neuron that was committed to death. It was great in the sense that it was a sign of pathology. It could be used for that, but it was committed to death. And I think what we now understand is that that is not true. That's still a neuron where there's a therapeutic opportunity, and we can rescue it, if not fully, but at least partially. And to me, that is really important. That's been based on both mouse data. Let's be fair, sometimes mouse data is still useful. So we've learned that, without TDP, neurons actually can hang around quite a bit. but it's also based on, the understanding that genetic modifiers of progression are actually downstream of TDP-43. That was really important. And I think that is just really important because it really kind of tells us that those neurons are there. They may be silent, they may be not effective, but we can still target them. And it doesn't mean we don't need to be more ambitious and actually develop therapeutics that are upstream, that avoid that totally, but it really gives us more options. It tells us that targeting on that phase is still a good idea, and possibly it's actually what we'll get to first. So that, to me, has really changed.
So this is a question I ask everyone, but so what about SOD1 and FAS, which have so much less overt, at least, TDP pathology, and yet clinically look so similar? Do you think of them as separate disease entities, or are the pathways common in ways that we haven't yet found out?
Well, and we've heard data, right? Even like today, and there's, people starting to find actually overlaps. And so I think, that needs to be looked at a bit more. So maybe we'll actually find that if we look hard enough, there'll be convergence. And I think that's still what we need to, it's been unfruitful in FAS and TDP, of course, initially 2 RBPs, we thought we'd immediately find an early convergence. That hasn't happened. But it doesn't mean that there isn't one maybe a bit more downstream. So I'm not sure I would consider them different. But, they're clearly great stratifications. And we're all talking about, stratifying. So that's a clear example. Yeah. We should keep that.
My bet is there's got to be a point where they converge somewhere.
Yeah.
Toby, you get grilled next. So, we've seen, Carole referred to this, so how frustrating is it to see many trials fail in the sense of they provide information, but not give a successful outcome in terms of benefit to patients. And some of those are even very well-validated genetic targets. So how do we understand that? And how do we do better for the next generation of excellent targets?
So, I think there's a couple points I'd make. I think I'd start with the concept of well-validated. I think that's probably changed over time. And I think we can continue to understand what that really means. For example, targets, we don't do it as much anymore, but targets based not in mouse biology now, but maybe human biology, human biofluids, human genetics. Of course, I think that would get general agreement. I think it probably goes a layer deeper than that. Just because you have a genetic target doesn't mean you really understand the biology of that target sufficiently to make an effective drug. I'd point to the Biogen C9 ASO study there. We had a very nice presentation that showed that the drug effectively got to the motor cortex, effectively got to the spinal cord, effectively modulated the sense transcript, but didn't help patients.
No.
And so I think there's a layer of sophistication to target selection and really understanding what it does and the directionality of your drug needed. So I think that's really important. The second thing I'll highlight, I think we just have to accept and move and use biomarkers in a fruitful way to screen out things we think will and most likely won't work. Neurofilament's the best tool we have. We will need others. We'll need pathway biomarkers like the cryptic exons. We'll need markers of target engagement, but putting these together, especially in early stage studies where making decisions on ALS functional rating scale is not appropriate, we just have to commit to that as a team and a community. I'll highlight, the Denali's excellent AIF2B study. It didn't provide effectiveness for patients, but the study provided important information. That sort of gets to my last point is when you get these studies that don't work, bringing forward the data, sharing not only the top level results, but the details of the biomarker work, the relationships, these are critical things too. So sharing is really a crucially important part as well.
Yeah, the more we can do that. And there's a great example at this conference of people doing it, Denali as well. So I'm going to move on to Carole. You get the visionary question. What can we do and what can Target ALS do to help today to make the next decade a success for ALS patients?
Yeah, thanks for that question, Chris. And I've been on the board of directors for Target ALS since 2020, and over the last 4 years, almost half a decade, the tremendous progress that we've seen is really quite amazing. And just to hear the quality of the science and the number of programs that Target ALS has touched. So in many ways, I would say Target ALS should continue what they're doing, which really is to fund, enable, and conduct research which they continue to do. And as a company that utilized the post-mortem tissue core even earlier than before I joined the board, to now seeing the data that's being generated from the Global Natural History Study and all of the data that's been generated on this basic science, I would say the single most important thing in the next decade is to continue to invest in this basic research. If we stop, we will not recover from that. And as we can see, this is a challenge that requires everyone in this room to continue to do the best science they can and really collaborate and apply that science to people living with ALS. And so I really hope that in the next decade, if we see the continued rate of progress we've seen in this decade, that we'll have cures for patients with ALS.
Thank you very much. And I'd just like, we'll finish the discussion there. I'm going to make a couple of concluding remarks, but thank you for doing this. It's a source of inspiration to me personally that you three, as well as all the others, are involved in this. I think that's really one of the reasons for believing in success. So I just want to make some very brief concluding remarks and say some very brief thank yous because of the time. So ALS is tough. Of course, it's toughest of all for patients and their caregivers and the families who live with them. But it's tough for the clinicians who have to give the diagnosis and provide solutions that are not yet satisfactory. But I also want to recognize, and I suppose I know it from experience, it's tough at the research level as well. It requires much patience. None of these new initiatives, none of these new targets you're looking at are going to pan out over the next 2 years into something simple. It requires real patience and acceptance that some of these leads are going to be wrong. And Carole referred to the unsuccessful clinical trials. That's really tough too, and it's especially for the people running them, the patients who gave their time and hope to those. So we've got to take it on. And I think a phrase we often use is we're going to chip away at the coalface. And so I use this illustration by Henry Moore of a coal miner, presumably back in England when I was young. And we think of that, as a really tough thing to do, but it's something we want to get done. So I thought I'd give just my little personal summary of where we might be in this process. And so in the past, so here's a sledgehammer going at the coalface, and undoubtedly there were many important breakthroughs even before Target ALS existed, and we should recognize those, and we're building on them. I mean, I think what all the work you've done and Dan's amazing fundraising efforts has done is to give us a sledgehammer that's 3 times bigger per year, and so much more powerful. And so you're helping swing this. Target is helping guide it and providing the resources for that. Yeah, and there's some bigger breakthroughs coming off in terms of those rocks. So, but in terms of the future, what should we think about? So I'm going to give a vision that's not mine really. I think it's shared by everyone in the room, and I know it's shared by Target ALS. We can't keep on increasing the size of the sledgehammer. It'll be too heavy to pick up. So I think what we need to do, in some way that remains to be defined, waiting for the animation, is to make it sharper. That means focusing on the weak points of the ALS and where we can really make a difference. And so that instead of just a few stones rolling off, we'll have the coal face that will completely give. And I'm sure that's going to happen. You've heard Dan say he's sure it's going to happen. It's not going to happen tomorrow. And then one of our strengths, I think, is that we've realized that from the beginning. But you here are actively involved in doing that and trying to take us to identify the bits that Target ALS and other funding sources should focus on in order to get to the end of this disease. So I'd like to end my comments there. I have so many people to thank. I would like to start by thanking Jennifer Agri and her whole team. This is by far the best run conference I go to, and that's due a lot to them, and so I hope they'll keep on working with us. I don't think they're here, so I won't stop for applause. I will stop for applause. Obviously, I want to thank Manish and Amy and the whole Target ALS team, but I'm concentrating on them for the scientific reasons. It's just amazing what they're doing with the resources they have. This meeting is just one small output of it, and you heard Amy's, I can't see Amy anymore, but Amy summarizing some of the things that have come out of it this year. It's just extraordinary to do that with these resources. So I would love to give them a very big round of applause. That big sledgehammer didn't come out of the sky. It came from the generosity of our donors. And obviously, I think of Dan and Elisa, who weren't here today. They decided that they weren't going to come for the full 3 days. I've had an opportunity to thank them in person and publicly before. But also all the other donors, of which some are in the room today. It's amazing that you believe in this. It's a long-term venture. It's a high-risk venture. But really, without you, we couldn't be doing it. So please thank them all. And last but not least, there's nothing wrong with self-congratulation. So give yourselves a big round of applause. It's amazing to sit here and every year see this new stuff, new collaborations, great data, not a single weak presentation this time round, I would say. So congratulations to you. Thanks for coming, and we'll see you next year.